Welcome to our webinar titled Treating AML in Older Adults. Thank you for joining us today. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions or comments at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do respectfully ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Martha Arellano, who is an Associate Professor of Hematology and Oncology, and also the Program Director of Hematology and Medical Oncology Fellowship Program at the Winship Cancer Institute at Emory University in Atlanta, Georgia. Welcome, and thank you for joining us today.
Thank you so much, Lee, and thank you for joining us, sharing this session with us. Share my slides here. Okay. So I'm going to talk about treating the AML in the older adult. My disclosures. So I'll start with some general review of information about AML. Describe some advances in the classification and molecular genetics in AML, and discuss new treatments for older adults, and then my overall approach to the older AML patient. So how common is AML? Another way to ask that is, what is the incidence of AML? So it is estimated that approximately 4 out of every 100,000 people in the United States will be diagnosed with AML per year. And the median age is 68. So as you can see here in this bar graph is that AML is very rare in children, in the pediatric population, and in the young adults. And then once we get to 60 and older, then it becomes to be, the incidence increases, it becomes more common. So it is inherently a disease of the older adult. What are the causes or risk factors for AML? This is generally what patients will ask me once I break the news. So the causes are not clear, they're not well known. There are a few factors that do contribute to an increased risk. Older age, again, with the average age being around 68 to 72 of these patients. And so it's a disorder of the older adult, and that's the main risk factor. Secondary AML is AML that develops after exposure to carcinogens, be it chemotherapy and radiation or radiation, and that's called therapy-related AML or T-AML, or a previous blood cancer like myelodysplastic syndrome, MDS, or myeloproliferative disorders. These can have a certain risk of progressing to the AML stage, if you will. There are genetic disorders that can predispose to AML, but these tend to be fairly rare. Generally, when we do take a very detailed family history to make sure that we pick this up if it's if it is happening. And then exposure to a chemical called benzene, which is a known carcinogen, can lead to AML and is similar in myelodysplastic syndromes. The genetics of this AML are similar to secondary AML. Men are slightly more likely than women to develop AML. So how do we diagnose and characterize the AML? So initially, the physician, the hematologist, and the pathologist will look at the blood and the bone marrow cells under the microscope. All we can tell is that these cells are abnormal and that they're leukemic, but we can't really tell what type of leukemia or the details about it. The flow cytometry is where we find out what type of leukemia it is, and it uses the markers on the surface of the AML cells or blasts, the leukemic blasts. They have markers on the surface and on the inside of the cell, and the flow cytometry uses antibodies looking that stain for those unique markers, and it can tell us whether the population of abnormal cells is AML or myeloid, or it's ALL or some other type of leukemia. Chromosomes can help us not only to diagnose the AML, but also to determine the prognosis of AML once the diagnosis has been made. And then fluorescence in situ, and when you look at a regular, what we call a karyotype of chromosomes, a set of chromosomes, you can detect about 1 in every 20 to 1 in every 30 cells. Fluorescence in situ hybridization, or FISH, the FISH test, is a type of chromosome test that can detect 1 to 100 to 1 in 200 cells, so it's more sensitive. And then molecular testing, looking for gene mutations. This is sort of like the needle in the haystack. You can detect up to 1 in a million cells in some instances, so it's a very sensitive test. And so AML is not one single disease. We know that the discovery of mutations that are associated with AML have helped us to better classify the AML, but has also provided potential targets for treatment. And so, for example, let's take this inversion 16, let's take the translocation 6-9 here. This is a chromosome abnormality. This is the gene that's involved with that chromosome. But in addition, this leukemia cell has mutations in FLT3 and a gene called KRAS. And so it's not just one disease, but it's sort of an amalgamation of multiple factors. And so previously, these gene mutations were only used to classify and risk stratify or prognosticate the AML. And now we're looking at potential targets for treatment. If you know what the problem is, then you can target it, hopefully. And we have several FDA-approved agents that are on the market now based on these, that are targeted against some of these mutations. So how is AML defined and classified? The World Health Organization, or the WHO, defines AML as myeloid blasts, the presence of myeloid blasts of at least 20% or more in the bone marrow or the blood, or a chromosome or gene mutation that is diagnostic or characteristic of AML. And there's a limited number of those. So you can have 10%, 15% blasts, and if you have a certain chromosome abnormality or a gene mutation, it's still AML. Or there can be a tumor that's, even if the bone marrow doesn't have leukemia, the leukemia may be forming a tumor, and that's called a myeloid sarcoma. And so the WHO classification is mostly based on chromosomes and gene mutations, but there are some other categories here that I won't go into details. The main one is AML with recurrent genetic abnormalities, or based on chromosomes and gene mutations. So doc, is my AML curable? What determines the prognosis of the AML? And so here we go with age again. Age, generally, it used to be said 60, older than 60. As I get closer to that age, I feel like that's not really older. So 60 to 65, we're pushing kind of that definition of what is older. And it's not just age itself, but it's because, so AML in these older adults tends to be less curable than in younger patients. And it's not just because the patient is older, but because of what comes along with being older. Chromosomes and molecular abnormalities, or those gene mutations, they tend to be, for most patients, the most powerful predictors of outcome, because you can have an 80-year-old that has a certain translocation, say a translocation between chromosomes 15 and 17, or the PML-RAR gene. That's a specific type of AML called a PL that has an excellent prognosis even in the 80-year-old. And so age itself is not the worst, the most powerful, but chromosomes and molecular abnormalities together with that. So some of these gene mutations will fall into a more favorable prognostic group. Some of them will be more unfavorable. And I'll go into that. Secondary AML also tends to have a worse prognosis than what we call de novo AML, or AML that are just came out of all of a sudden without having had another predisposing condition or haven't been exposed to chemo or radiation. So prior radiation or chemo, that's called therapy-related AML or TAML. And having had a previous disorder like MDS or myeloproliferative neoplasm disorder, it's called SAML, secondary AML. Performance status at the time of AML diagnosis is especially important in the older patient. And performance status means how healthy is the patient, how active are they up and active all day versus resting most of the day because of the symptoms. And the symptoms of leukemia or the symptoms of another serious issue, medical problem that the patient is dealing with. And so this is important. There was a study from Dr. Fred Applebaum in 2006 in Seattle where they looked at performance status in all the patients that came in and got the strong chemotherapy. The only option at that time was the strong induction chemotherapy. And they found that if you were 25 and you were bedridden from your AML, you did almost as well as if you were, running laps in perfect physical shape. Now, if you were 80 and you were bedridden, then the mortality from that chemo was up to 80% versus less if you were, someone like a patient that I had that was lifting 100-pound weights and, running marathons. And so the performance status is more important in the older patient than the younger patient. And then the white blood cell count at the time of diagnosis is not a very strong factor. It's more of a marker of whether the patient has to be treated urgently, emergently, or they can wait a little bit. And so the European Leukemia Net, or ELN, the 2017 update, takes into account the chromosomes and gene mutations and categorizes AML into a favorable group. Example here, this core binding factor group, which has a translocation between 821 or an inversion of the chromosome number 16. So this favorable group is more likely to get cured with chemotherapy alone, chemo and or targeted, with or without targeted treatment alone, and does not have to have a transplant. The adverse or unfavorable group, these patients with what we call complex karyotype, where they have 3 or more chromosome abnormalities, tend to have, and these others, TP53 mutations are notoriously bad. And so these patients are very unlikely to get cured with chemo treatment or targeted treatments or the combination alone. And so for these patients, if they're healthy enough, we offered transplantation. I'll go into that a little bit more. And so this is the outcome comparing the younger patients versus the older patients based on that ELN-17 cytogenetic and molecular risk. And so this is the estimate of 5-year survival for patients who, these patients did receive treatment. They received induction types of chemotherapy. And they looked at age 18 to 86 years. And for patients under 60 years of age, the cure rate was actually 64% for that favorable group versus 20% for the adverse group, and in between for that intermediate group. Whereas for the 60 and older patient, the favorable patients had a cure rate or a 5-year survival of 37%, so less than that intermediate group, a little better than the adverse group in the younger patient. And the adverse and intermediate group looked very similar with long-term survival rates much less than 20%. And so what are some of the reasons for this worse prognosis in the older AML patient? We know that there are patient-related factors, comorbid conditions, hypertension, diabetes, other medical problems, poor organ reserve, like issues with the heart, lungs, kidneys, liver, and these can make it more difficult for the patient to tolerate the strongest or maybe the best type of treatment for them. And so, so it's not age itself, but it's what comes along with it. There are also disease-related factors, such as just sort of an inherently more resistant AML in the older patient, lower incidence of those favorable chromosome abnormalities and gene mutations, higher incidence of that secondary or treatment-related AML as treatments improve for other cancers, such as prostate cancer, breast cancer, colon cancer. That exposure to chemotherapy and or radiation then will leave a certain risk of patients developing AML in the future. It can be up to 15% in some groups. And there may be physician-related factors, although that's not the case as much anymore. Now that we have more options that are not intensive induction treatment for the older patient, physicians that are not AML specialists are becoming more comfortable with treating older patients and also those who have other health issues. This was some data from investigators who looked at geriatric assessment. And basically they did 2 tests, a short physical performance battery and a modified mini mental state. So a test of physical fitness and sort of mental fitness in these patients. And the patients were they were 60 and older, undergoing strong induction type of chemotherapy. And what they found out was that a poor score on the short physical performance battery, if patients were less physically fit, the survival was less, the toxicity from chemotherapy initially here in that first 30 days was much more for the physically unfit patients versus the fitter patients, although you still see a lot of patients that were lost during that first 30 days. And then the same with mental fitness. So a lot of depression, anxiety, and so forth. And I think it's not just important to determine prognosis in these patients, doing these assessments, but also so we can help, because there are potentially modifiable factors. Physical fitness in some patients can improve. If people became very weak suddenly because of the acute illness, then that's a patient that if we do some intensive physical therapy, rehabilitation, that patient may be able to improve to the point where later they can tolerate the more intensive treatments. And the same with mental health. And so I told you that older AML patients tend to have more of those unfavorable chromosomes, chromosome abnormalities, and fewer of those favorable abnormalities. You see here after in patients older than 75, over half of them have unfavorable or adverse risk cytogenetics, and only less than 5% have the favorable. And this is some old data. If you look now, including those gene mutations, this is going to be way higher than 51%. So it's just a more aggressive disease inherently. And so as we determine the prognosis for these patients and try to make a decision on the best treatment for them, it's like assembling a puzzle where, you know, how do we get to, from a bunch of loose puzzle pieces or of information to put the information together and have a clearer picture of what we're dealing with, and then guide our patients toward the best treatment for them. And so if you take into account age, and you know, I want to emphasize that it's not just number of years lived, but those pre-existing medical conditions that come with age, the performance status that affects, that has more of an effect in the older patient, and then leukemia-related factors like the chromosome abnormalities and the AML blasts, gene mutations, secondary AML from prior leukemia or prior radiation or chemotherapy, and then the white count tends to be a weak factor. So you put all those things together and you start to get an idea of what the best treatment might be for the patient. So the AML subtype, patient age and general health, can't forget the medical history, medications that the patient has to take, the family history. And then we set some goals for that patient. Are we going for a cure? We would like to go for a cure in every patient, and my hope is that one day we will be there. But for now, we have to be realistic, and we have to find out what our patients have as their goal, and because we make decisions together. So the goal for the patient, cure versus I want to get into remission, I don't want to die during the initial attempt, and I want to stay in remission for as long as possible. So it's important to have those conversations. Some patients may need treatment urgently, but others may benefit from learning more about their own version of the leukemia before starting treatment. Because if we rush to start induction chemotherapy, put the patient in the hospital for 4 weeks, blast them with chemotherapy with 7+3, and then you know, a certain proportion of patients will die from toxicity from the treatment. And then we find out that, oh, they have that TP53 mutation. Chemotherapy doesn't really work on that so well. And so the risks really overwhelm the potential benefits from that treatment. So for a lot of patients, it is best to take our time and get more information. And so this is an overly simplified graph of what AML treatment might look like. So induction chemotherapy. In previous years, when we talked about induction, we had in mind only one treatment. That was something called 7+3, a combination of 2 drugs. It's given in the hospital. Patients are knitted for a month. They lose their hair. There can be a lot of toxicities. And so that's on, we call that intensive treatment, appropriate for fit older patients or younger patients that are also fit. Versus non-intensive treatments, which we have now for the past couple of years for older patients or less fit patients. And then if we can get the patient into remission, then consolidation. So there's the fit patients will have an intensive consolidation, or the less fit patients may have just continuation of the same treatment that they got for induction. And then the adverse risk patients, are they candidates? Are they strong enough to withstand going through donor transplant, allogeneic transplantation, based on adverse risk of the leukemia? Or there's a new maintenance treatment for patients who cannot go to transplant, or continuation of the same treatment, of that non-intensive treatment for those patients who the goal is to get remission and keep them into remission as long as possible, but we know that the treatment is likely not to cure them. And of course, supportive care and palliative care and careful monitoring all along the way. So we've come out of the dark ages with AML treatment from the early 1970s, where the only treatment was that induction chemotherapy that I talked about, the 7+3 regimen for AML. It's the regimen that's used in a lot of centers still. A lot of trials have tried to do better than AML, but than the 7+3 regimen, but it is still the standard in a lot of places around the world. In 2000, so nothing happened. The first transplant was employed also in the late 70s. A drug called gemtuzumab ozogamicin, which is an antibody against something called CD33, was approved in the year 2000. And then it was taken off the market in 2010 due to some specific liver toxicity. And then in the past 3 years, we sort of saw like blasting off of FDA approvals, drug improvements in drug development with 9 agents approved. And so, and these 9 agents, I'll just go briefly, 2 targeted treatments that inhibit that FLT3 mutation. So something called midostaurin, one called gilteritinib, a strong treatment, an induction treatment that's targeted toward older patients that have that therapy-related or secondary AML. There is an IDH2 and an IDH1 targeted treatment approved. There's something called a hedgehog inhibitor, glasdegib, and then venetoclax, which I'll go into, which is really the new standard for newly diagnosed AML patients that are older or that are too frail to undergo induction chemotherapy. And then there's an oral maintenance treatment that was just recently FDA approved this past September. And so FLT3 is what's called a tyrosine receptor tyrosine kinase that's involved in the in normal development, but when it's of stem cells, but when it's mutated, then it can cause be associated with sort of uncontrolled growth, high percentage of blasts, and a poor prognosis, especially in AML with normal cytogenetics. And this FLT3 can be mutations or internal tandem duplications, and they're present in up to 40% of patients with AML. And so midostaurin is the first FLT3 inhibitor that's been FDA approved based on this randomized trial that used that 7+3 induction regimen followed by consolidation with or without the midostaurin. So there was a placebo. Everybody got the standard induction, and then the research group, the study group, got the midostaurin, and the control group got the placebo. What they found was that midostaurin was associated with improved survival. As you can see here, 74.7 months compared to 25.6 months for the 7+3 group without midostaurin. And so that was FDA approved based on this study. Gilteritinib is also a very potent FLT3 inhibitor that was FDA approved for relapse refractory AML. It's being studied for newly diagnosed AML. The complete remission rates, complete remission or complete remission without recovery of platelets or without recovery of neutrophils was 54% compared to almost 22% for the chemo. So it's a single pill compared to a combination of chemo drugs was better. Gemtuzumab ozogamicin, which I've already mentioned, is a CD33 antibody that's conjugated with type of chemo drug derived from an antibiotic agent. It was tested, it was approved. So it was initially approved in 2000 and taken off the market in 2010, and then reapproved in 2017, mostly based on this study and another one. This was the main study. So it was a randomized phase 3 study. So patients got the 7+3 induction with or without the GO, gemtuzumab ozogamicin. So they could get up to 2 inductions and then 2 consolidations. And this was in older patients, 50 to 70, with newly diagnosed AML. Now this was de novo AML, not the secondary or treatment-related AML patients. And so what you see was that event-free survival, so surviving without relapsing, in about 41% of patients in the GO and induction arm versus 17% of patients in the 7+3 arm alone without GO. And then overall survival was better in the GO in 7+3, the combination arm, 53% versus 42% in the 7+3 arm alone. And so what was noticed also that most of the benefit of adding GO to 7+3 was in that favorable cytogenetic group, especially a group called the core binding factor group. You can see here on the left is improved survival with GO, and on the right is reduced survival. And you see that those patients with the unfavorable or adverse risk chromosomes were the ones that did not benefit. And so for us, we add GO to to patients undergoing induction, both younger and older fit patients who have those favorable chromosome abnormalities, the core binding factor patients, translocation 821 and inversion 16. And this drug, CPX-351, is a liposomal combination of those two drugs that are in 7+3, so cytarabine or ARC and daunorubicin, and it's in a 5:1 molar ratio so that the ratio stays the same throughout the infusion. And it was tested against that conventional 7+3, standard 7+3, in older patients with newly diagnosed secondary AML. And so patients were untreated. They had either treatment-related AML or AML secondary to like an MDS or myeloproliferative disorder. Patients were ages 60 to 75, and they had to be candidates for intensive chemotherapy. And so what they found was that, again, the remission rates were better, 47.7% for the CPX-351 group, 33% for the 7+3 arm. Overall survival was better. It was 9.56 months for the CPX arm compared to 5.95 months for the 7+3 arm. And event-free survival was also better, so not relapsing and not dying. It was better for the CPX arm. And they also noticed that, so a lot of these patients, because secondary AML tends to have a poor prognosis, a lot of those patients went on to transplant. In the CPX, the patients who were in remission at the time of transplant after getting CPX-351 did better than those that got the 7+3. So another group of targeted drugs, and probably the biggest story in the past few years, was targeting a gene called BCL2 in AML. So BCL2, this gene, overexpression of it allows this gene to not do what it's normally supposed to do to control cell death or apoptosis. And when it's mutated, then it does not, it allows apoptosis to continue unchecked. So so it takes those checks and balances from the cell. And ABT199, or venetoclax as it is known now, inhibits this BCL2 gene to allow apoptosis to progress normally, so cell killing. Venetoclax is a BCL2 inhibitor, and it was studied with decitabine or azacitidine. We call those hypomethylating agents in newly diagnosed AML patients aged 65 and older who were unsuitable for induction chemotherapy. The remission rate was higher than anything we've ever seen with a low intensity treatment in older patients with AML, 67%. And so it went on to a phase, and it was FDA approved based on this data. And so after we discovered what the right dose was, then it went to a phase 3 clinical trial looking at azacitidine, otherwise known as Vidasa, with or without the venetoclax. So azacitidine, venetoclax versus azacitidine placebo in newly diagnosed patients with AML age 75 and older or younger with pre-existing conditions precluding delivering of induction chemotherapy. And so patients were randomized actually 2 to 1 to azacitidine venetoclax versus azacitidine placebo. And here the remission, the composite remission rate was much higher, 66%, and the median survival was 15 months for these patients. And in the azacitidine placebo arm, the remission rate was 28%, so 66 versus 28%, with a median survival of less than 10 months. So this drug was initially approved in an accelerated approval type of manner, and then this phase 3 confirmed that the right decision was made, confirmed the activity. And so venetoclax was also approved, tested and approved in combination with low-dose cytarabine for previously untreated AML patients. That was based, again, on a phase 1b/2 clinical trial. The remission rate was 54% for those patients, but you can see here those that had been exposed to hypomethylating agents, the azacitidine, did poorly compared to those who had not been exposed. IDH1 and 2, these IDH1 enzymes, both IDH1 and 2, are involved with the Krebs cycle. They convert something called isocitrate to alpha-ketoglutarate, something that is very important for normal metabolism and development of cells. When these two genes, IDH1 and 2, are mutated, then they sort of hijack that alpha-ketoglutarate, turn it into something else called 2-hydroxyglutarate, and then this 2-HG becomes like food for the cancer cell. It prevents the normal function, the normal things that would happen with alpha-KG. And so we call that an oncometabolite. And so inhibiting these mutated cells was shown to work in animal models and test tubes, and it was then tested in humans. And so the drug ivosidenib, or AG120, is an IDH1 inhibitor that was FDA approved for both relapse and relapse refractory and newly diagnosed AML. The remissions in newly diagnosed AML, it's a pill, 43%, and in relapse refractory, 33%. And the phase 3 with the azacitidine, with or without the ivosidenib, is still ongoing, almost done. And azacitidine is the IDH2 inhibitor, and it's been FDA approved for relapse refractory AML with a remission rate, also an oral agent, of 23%. And so stem cell transplantation, just one slide. Allogeneic transplantation, that's from a donor, is what's generally used for AML in the adverse risk patients. Autologous may help for a specific type of AML, but is generally not used in AML. Reduced intensity type of conditioning for transplant is geared toward older adults. And so there's some data showing that even older adults who have a donor transplant, those with adverse risk, can do just as well as younger patients if you use that reduced intensity conditioning. And the factors that influence whether a transplant is an option or will succeed: the age and fitness of the patient, genetics of the AML, the adverse risk patients, the secondary AML, availability of a donor, and the patient has to be in remission. For those patients who cannot go on to transplant, then there's a brand new maintenance treatment that was FDA approved. It's an oral azacitidine, so azacitidine can be given normally subcutaneously under the skin or intravenously. This is an oral, this is a pill, based on a phase 3 randomized, double-blinded, placebo-controlled study looking at 472 patients. Now, these patients were 55 and older. They had de novo or secondary AML. They were in remission at the time that when they went on to the study. And so they had already induction chemotherapy, the strong, that 7+3, and 1 to 2 or more consolidations. And so, and for some reason, they couldn't go to transplant, which is what I find puzzling about, a little bit about this trial, because they were strong enough to have all that previous treatment, and now they can't have a transplant. And so the survival probability for these patients was higher, was 24.7 months for the maintenance arm versus 14.8 months for the no maintenance arm, for the placebo arm. There is a clinical trial that is a collaboration with several academic institutions, pharmaceutical companies, the Leukemia Lymphoma Society, and the FDA. It's called the BEAT AML trial. It's a trial that recognizes that one size does not fit all, and it's targeted treatment for patients older than 60 with newly diagnosed AML. And so basically, patients with untreated AML at the time of diagnosis, they sign a consent for a main study. We call it the master trial. We get a bone marrow aspirate, sent off to a special lab, and we get that genetic information within 7 days. Normally, those the chromosomes can take a couple of weeks, in some places up to 4 weeks, and the gene mutations can take up to 4 weeks as well. So we don't have that information before we start treatment. And so this treatment, in this trial, you get that information within 7 days, and then you can tailor the treatment to that individual's leukemia. And so then they sign another consent for a sub-study, and their assignment is based on the curability of the patient and the disease. So for those core binding factor patients or the NPM1 mutated patients, which are favorable, there's an induction type of treatment for those patients. And then beyond that, you look at which mutation is the dominant one, and then the size or allelic frequency of the mutation. So there are all these sub-studies. And then if there's no marker, then there's a standard treatment for the marker negative patient. And so everybody gets treatment, and it's based on their genetics of their own leukemia. So this is a very limited list of there's a lot of drug development going on to try to find a cure for AML, including immunotherapies, all types of immunotherapies, all types of targeted treatment. So clinical trial is still the best option for a lot of patients, if not most patients. And so my approach to the older patient with AML, newly diagnosed, you do the urgent things to take care of them. You screen them for a clinical trial first, because still clinical trial might be the best choice for most patients. And if you have rapid turnaround of all this information, you may be able to find out those patients who can benefit from those strong treatments right off the bat versus those who will not be cured with that, and the toxicity may outweigh the benefit. And so we get all our information, and then the first question we ask is this patient fit? So the age has something to do with it, but ultimately, can the patient tolerate induction chemotherapy? So if they can, then 7+3 or an equivalent regimen, CPX-351 if it meets the package label for therapy-related or secondary AML, AML with myelodysplasia-related changes. You add a FLT3 inhibitor, midostaurin, if they have a FLT3 mutation, and you add GO if it's the favorable, the core binding factor. So for the fit patient, induction with along this line. And then consolidation is risk adapted. So for those that have FLT3, we know that FLT3 is a poor risk, so we're going to evaluate them for transplant. We might be doing this all along from the time that we determine that they're fit. You have to have sort of the plan for now, but already be making the plan for later. For the unfit or physically frail patients, then you have to confirm the goals of care. What are we trying to do here? There are patients that will opt for supportive care alone or hospice that are not strong enough to even have the non-intensive treatment. But for most patients, I do offer treatment, whether it's on the BEAT AML trial. I offer that to all my patients, 60 and older. And then azacitidine and venetoclax, it's a new standard for patients that cannot undergo induction. And then if they're not fit enough, so at this point they're not fit enough to have induction, it might be that with a few cycles of AZA, venetoclax, and a few rounds of physical therapy that they could improve and then become transplant candidates. And we have shown that about 10% of all patients on these clinical trials with venetoclax combinations went on to transplant, and some of those will be cured. And then for relapse patients, a clinical trial or a targeted agent if they have these targets. And so in summary, AML is a heterogeneous disease and outcomes depend on both patient-related and disease-related factors. We have come out of the dark ages with AML treatment with 9 new FDA-approved regimens in the past 3 years, but we haven't cured AML yet. So we need to keep doing research and participating in clinical trials. There's a new standard treatment for the older AML patient who are unlikely to tolerate induction chemotherapy. Allogeneic transplantation is still the only potentially curative treatment for the high risk or adverse risk patients with AML, and reduced intensity conditioning programs can expand the use to the older patients. So older patients can also benefit from transplants. And clinical trials are still the best option for many patients. Thank you.
Thank you so much for the wonderful presentation. We do have a few questions. One question is, what does it mean to be transfusion dependent? And does being transfusion dependent impact the outcomes of a treatment?
So being transfusion dependent means, so with AML, the disease kind of takes over the bone marrow. Either those leukemia blasts will fill up the bone marrow and prevents it from making normal healthy cells. And so the red cells will be low. We measure that by hemoglobin. So anemia, if you get anemic enough and your bone marrow is not making enough cells to give you that hemoglobin and the energy, then you become transfusion dependent because your bone marrow is basically not producing enough of your own healthy cells. That happens also with platelets. Now we can't transfuse white blood cells, so transfusion dependence means either dependent on red cell transfusion or platelet transfusion. And it can affect what type of treatment you're offered. So for patients where transfusion is not an option, then we can't do those strong induction types of chemotherapy programs because those treatments wipe out everything in the bone marrow, including the good cells and the bad cells. And then you spend some time waiting for the bone marrow to recuperate, to make cells again. And during that time, if we don't transfuse, then patients can die of anemia, bleeding, things like that. So, but hopefully if the treatment works, then the bone marrow can, if you clean out the blasts from the bone marrow and then allow it to produce healthy cells, that's why we admit patients to the hospital. That 7+3 regimen is only 1 week, but it takes about 3 weeks for the bone marrow to regenerate and start producing healthy cells again, so that the patient's no longer transfusion dependent. So when someone is in remission, they're also not transfusion dependent anymore.
And does having multiple transfusions and you develop iron overload potentially, does that impact the effectiveness of treatments moving forward, or the effectiveness of possibly having a successful transplant?
So iron overload, it's more of a problem with patients. So it's not so much a problem with patients who received a strong induction treatment because the period of transfusion dependent is limited. And so generally patients don't get iron overloaded from repeated transfusions of red cells. So it's more of an issue with MDS, or for patients who are getting the more protracted treatment that haven't gone into remission. And iron overload can affect transplant outcomes, but in AML, it's more of an issue with MDS patients who are transfusion dependent for a long, long time.
Thank you.
So we don't use iron chelation for AML patients.
Thank you. For patients who are diagnosed with MDS and considered high risk and the risk of AML, what is the difference between being an 18% blast and a 20% blast? Is there really a difference in, you know, once you hit that 20% blast, you're considered AML. So what's the difference between being 18 or 19%?
Wow, that's a great question because we often, so a lot of times our pathology colleagues will give us, may give us a range of this patient has between 15 and 22% blast. And so you know that 20 is AML, so 22 is AML, 15 is MDS. I really, the WHO had to choose a cutoff to define the disease, but I think the difference is arbitrary. Someone with MDS with 18% blast probably might behave the same as an AML with 20% blast. And so some of those treatments, like the venetoclax combinations, they're being studied now in the high-risk MDS patients as well.
Thank you very much. What about CAR T-cell therapy? Is that an option for AML patients?
Only in clinical trials right now. So we have, there are bispecific T-cell engagers, BiTEs. There are drugs called DARTs. There are CAR T-cell treatments. There are vaccines. So a lot of immunotherapy type of drugs that are being developed for AML, but none of them are ready for prime time yet. They're in clinical trials.
Well, thank you so very much, Dr. Arellano, for spending your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question, or you didn't have a question to ask but have one later, please do feel free to send us to us at any time in 3 ways. Send an email to our help account, which is help@aamds.org. You can call our help line at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 37 years. This concludes our program. Thank you so much.
Thank you. Have a great day.